Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Oksana Prokopchuk-Gauk, a hematologist and transfusion medicine specialist working in Saskatoon, discusses considerations surrounding perioperative transfusion medicine. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So these are my disclosures. It's a pleasure to be here this morning. So the objectives were circulated prior to today's talk, so why don't we just dive into the first, which is to summarize the current approach to red blood cell unit selection for patients with sickle cell disease to mitigate the risk of hemolytic reaction. So each of the three sections today will begin with a case. So this is a 26-year-old male with known sickle cell disease that presents to emerge with progressing abdominal pain, nausea, and vomiting during the previous 3 days. He reports that his urine is increasingly tea-colored, but hasn't noticed any rectal bleeding. His history includes multiple previous hospital admissions for pain crises, as well as many blood transfusions to date since childhood. His last was about 10 months ago, and he's had an estimated total 20 units of red cells throughout his lifetime. He's under the care of hematology and is taking hydroxyurea daily. His vital signs include a normal oxygen saturation, relatively so, at 94%, with a respiratory rate of 22, stable blood pressure and heart rate 110. And his temperature is a little bit on the higher side, but not quite a fever yet. Physical exam includes mild scleral icterus, clear lungs, but a tender right lower quadrant. CT abdomen confirms presence of acute appendicitis. So this is blood work. You notice he's mildly anemic, but that's actually pretty good for a sickle cell disease patient. Platelets are a bit high, as are white cells, as he's inflamed. He's got a slightly high LDH and bilirubin, which is mostly indirect, which gives you some suspicion of maybe some degree of hemolysis. Renal function's normal. And then from the pre-transfusion testing side of things, he's group AB positive, and he has an anti-big C and an anti-big E antibody. So he's already demonstrated himself to be an antibody former. So in the emerge, he's gotten some oxygen, IV fluids, pain medications, antibiotics. Gen Surg has seen him, and they want to do an appendectomy, and of course, anesthesia gets involved as well. So fundamentally, the question is red cell transfusion necessary as a part of preoperative management in this patient with sickle cell disease? So I'll let you think about that just for a couple seconds, and we'll get back to the case in a few slides. So as I'm sure most know here, sickle cell disease is a single gene disorder where there's a DNA base pair change in the beta globin gene that produces hemoglobin S rather than having a normal hemoglobin A. So people who are sickle cell trait have hemoglobin A as well as hemoglobin S, approximately in a balanced mixture, but anybody with sickle cell disease has no hemoglobin A. It's autosomal recessive, and it can either be a variant with hemoglobin C or beta thalassemia as well. About 3 million people are affected worldwide, with about 100,000 in the US, but immigration is increasing rates both in the US and Canada. And we know that about 300,000 infants are born worldwide with hemoglobin S every year. So with this increase in immigration patterns, we are seeing more sickle cell patients in Saskatoon and Regina than ever before, but sometimes they do live in rural Saskatchewan as well. So this isn't just a rare population anymore. We're seeing more and more sickle cell patients, particularly in the pediatric realm. Sickle cell disease is characterized by chronic hemolytic anemia that causes episodes of acute chronic pain and end organ damage due to consequences of sickle cell red cells. All organ systems can be affected, and there is certainly a documented premature mortality with individuals having a shorter lifespan by about 20 years. So effective management really requires early diagnosis and fundamentally prevention of complications to reduce the progression of end organ damage. So in terms of sickle cells, hemoglobin S polymerizes when deoxygenated, and this induces recurrent sickling and hemolysis. The sickled red cells interact with white cells and platelets on the vascular endothelium, by adhesion molecules that ultimately lead to vasoocclusion. The free hemoglobin and heme released from red cells during that hemolysis triggers endothelial dysfunction because of scavenging and depletion of nitric oxide, which of course is an important smooth muscle relaxant. But in patients with scavenged NO, this causes chronic vessel tightening. And so together, vasoocclusion and endothelial dysfunction ultimately activates inflammatory responses, and with these increased cytokines and reactive oxygen species, perpetuates further vasoocclusion. So it's just this constant feedback loop of causing vessel tightening and ultimately pain in the patient. And so at the bottom here, there's a timeline of sickle cell complications that really shows the progressive morbidity throughout the individual's lifespan. So in terms of treatments, these are intended to prevent crises and reduce symptom severity to decrease complications. Hydroxyurea is a maintenance therapy that's standard of care, and it works by inducing production of fetal hemoglobin to reduce the proportion of hemoglobin S. So whereas a normal fetal hemoglobin is in the 3% range, we really try and push up the fetal hemoglobin in patients with sickle cell disease to 8 or even 10%. But not everybody responds, so not everybody gets the same benefit from the hydrea. Red blood cell transfusions are an important part of sickle cell care because it replaces the pathological sickled red cells with healthy red cells. It's effective in treating and preventing complications, but the big caveat is that the decision to transfuse requires clinical hematology expertise because this is certainly not a benign therapy in patients with sickle cell disease. Communication of the diagnosis to transfusion medicine is essential because we have strategies which will help to reduce alloantibody formation or reactivation, because sometimes patients have antibodies that kind of fall away and then their antibody screen looks fine and negative, but there are really low-lying antibodies that are present. Knowing about the diagnosis also helps us to mitigate the risk of hemolytic transfusion reactions based on our blood matching, and we'll talk a bit about that. And certainly, appropriate communications and strategies employed can reduce death from red cell transfusions. There are some unique reactions that can impact the sickle cell population, and I'll touch on those as well. So from a preoperative transfusion care perspective, there was a sentinel trial that was published back in 2013 called the Transfusion Alternatives Preoperatively in Sickle Cell Disease, or TAPS trial, that actually changed our approach to perioperative care in patients with sickle cell disease. This is a multi-center randomized controlled trial, including patients with severe sickle cell disease age 1 year or older, so included both pediatric and adult patients, that were scheduled for low or medium risk surgery. So that included abdominal, ENT, and orthopedic surgeries. Random assignment was to either a transfusion or to a no transfusion group more than 10 days before surgery. And in the transfusion group, if people were allocated to that arm, there was a target pre-operative hemoglobin of 100 grams per liter, which also had a goal of reducing the circulating hemoglobin S to less than 60%. So again, with transfused red cells, you're replacing with hemoglobin A, so that essentially dilutes the relative proportion of hemoglobin S. If patients had a hemoglobin of over 90, they underwent a partial exchange, red blood cell exchange, to get that hemoglobin S down to target. The primary outcome was the proportion of clinically important complications between randomization and 30 days after surgery. So 81% of patients ended up being randomized who had a medium risk surgery underway. And if we compare the preoperative transfusion versus no preoperative transfusion group, you can see that there were a lower number, statistically significant and clinically significant lower number of important complications in the transfusion group, and only one serious adverse event, the majority of which were acute chest syndrome. A significantly lower amount happened in the pre-op transfusion group. So the results of this study suggested benefit of pre-op transfusion before low and medium risk surgeries, and this has actually become a part of standard care with our patients who have sickle cell disease. The CanHeme group has also put out a perioperative management consensus statement, and you might be surprised at the year. It's still from 2015, but there really haven't been any other high-quality randomized trials involving sickle cell disease and blood transfusion in the perioperative setting since that time. So they continue to recommend that patients undergoing lower moderate risk surgery should receive prophylactic transfusions to that target hemoglobin of 100 to ideally reduce the hemoglobin S to less than 60%. And if patients are going for high-risk procedure, the overall recommendation is for patients to actually have a red cell exchange and target hemoglobin S of less than 30%. So they really need to be treated uniquely. Along these lines, after the notification to the blood bank occurs, there's a lot that happens on our end to make sure that patients get the best blood that they can to prevent complications. So as mentioned, in sickle cell disease, there's an alloantibody formation risk. A patient that has also formed antibodies, like the one in our case here, is at further risk of forming additional antibodies. So history of red cell antibody formation is a risk factor for more antibodies. We also know that there's RHD gene and RHCE genetic diversity in patients with sickle cell disease. So these are the genes that encode the Rh blood group, predominantly the D antigen, as well as big C, little c, and big E and little e antigens. So up to 39% of sickle cell disease patients have been identified to have Rh gene variants. And the reason that's important is because if the sickle cell patients who are recipients of transfusion have a gene variant, they're going to see wild type antigens on donor blood as not quite the same as theirs. And there may be epitopes that they form antibodies against as well. So there is sort of this heightened sense of seeing differences in the antigens that can actually lead to antibody formation. Overall, the alloimmunization risk is up to 13% with red cell transfusion in patients with sickle cell disease, and some studies have actually shown higher. The 13% is an average, but certainly it can even be more than that. I really like the graphic, although it's a bit small on the slide there, that depicts red blood cell surface because it just reminds us that the red blood cell is not bald, and it's also not just ABO and RHD. There are over 366 described red cell surface antigens belonging to 47 different blood groups. And so really any of these antigens can potentially be immunogenic. Some are more clinically important than others, but we do know as well that patients with sickle cell disease sometimes will form antibodies against antigens that in the general population we really don't think about or we don't care about. But they form, and then we need to take extra care to make sure we're providing units that are negative for those particular antigens. So in terms of the most common antigens that we look at on the red cell surface, certainly ABO and RHD. If we only provide red blood cells that are matched for ABO and RHD, this leads to a delayed hemolytic transfusion reaction risk that's increased over the general population, and it's about 1.94 antibodies over 100 red cell units transfused. If we provide a higher degree of matching beyond ABO and RH, that also includes the C and E antigens as well as CAL, we can reduce that by over 4 times. So this is very important on the transfusion side. And of course, we can't provide a higher degree of matching unless we know that the patient themselves has sickle cell disease. Another aspect that sometimes gets asked is, should we be providing fresher red cell units to patients with sickle cell disease? And the answer is no. The age of the red cell unit selected has no influence on clinical outcomes. So whatever we have in the blood bank is what we get that's phenotype matched. And the shelf life, as you know, is up to 42 days. It's actually very unusual for a patient with sickle cell disease to require irradiated blood unless they've had a bone marrow transplant or are imminently going for a bone marrow transplant. And we have children that are in that situation to actually cure their sickle cell disease. So otherwise, it's sort of standard issue red cells for the sicklers. So transfusion risks are really important to be aware of because certainly from the hemolytic perspective, the risk is higher than that of the general population that gets transfused. So hemolytic transfusion reactions are always what we consider to be a never event in transfusion medicine, particularly from ABO mismatch. However, patients with sickle cell disease can have perfectly ABO matched cells, but still develop acute hemolytic transfusion reactions. Sometimes it's due to anti-A, for example, or anti-B subtype antibodies, but Often it can be from other naturally occurring antibodies that, again, we're not detecting because they're, sort of below the level of our clinical significance, but they can happen they can have a high binding affinity, or they can sort of become a problem when we don't even expect them to be a problem. So acute hemolysis occurs up to 24 hours after transfusion, and this is due to some semblance of pre-existing IgM antibodies, more so than IgG. So the IgM antibodies are large pentameric, like five-sided snowflakes, so to speak, and when they bind red cells, they activate complement, and that's actually a big problem. Complement leads to development of a membrane attack complex in that lower circle, and actually leads to holes being punched within the red blood cell membrane and spilling of hemoglobin and heme moieties into the circulation that can cause all sorts of problems with inflammation and renal damage. There's also an essence of activation of mast cells with the complement mediation, and that leads to increased capillary permeability, and vasodilation can lead to hypotension as well as fever and DIC, which causes all sorts of end organ damage as well. Delayed hemolytic transfusion reactions happen beyond 24 hours from transfusion and have a different pathophysiology. So unlike the IgM-mediated acute hemolysis, this hemolysis is IgG-mediated. And intravascular hemolysis, IgM-mediated, occurs very rapidly. This delayed hemolysis is from IgG antibodies that essentially tag red blood cells and cause macrophages to pinch out portions of the red blood cell membrane and essentially cause sort of a slow degradation of the red cells and hemolysis. So it's considered extravascular because it all occurs in the spleen, but can ultimately cause an increase again in that bilirubin in circulation, and ultimately jaundice, T-colored urine and the like, because the red cells are lysing. So certainly anemia is a part of this aspect too. So historical antibodies can actually be missed on antibody screen because of something called evanescence. And that's essentially when that titer falls below the detectable level, our antibody screen looks negative. And then all of a sudden, sort of 5 to 10 days later, patients are developing this hemolysis. And then the antibody is detectable thereafter because it's stimulated to actually be produced in a higher amount by the B cells. So the most severe form of delayed hemolytic transfusion reaction is actually called hyperhemolysis. So hyperhemolysis is a very scary complication of red blood cell transfusion. And that's when there's hemolysis not only of the transfused red blood cells, but something happens and there's an autoimmune reaction as well that also causes hemolysis of the patient's own red blood cells. And so this is quite a dangerous situation for patients, because what ultimately happens is a transfusion is given to a patient, and then the post-transfusion hemoglobin within a relatively short course, like within an hour or two, can be lower than the pre-transfusion hemoglobin. And it's not because of bleeding, it's because of rampant hemolysis. We know that there's complement dysregulation involved, and that there's also a concurrent suppression of erythropoiesis. So we see low reticulocytes as well as very prominent hemolytic markers. The strategy for hyperhemolysis management is essentially don't transfuse them. And sometimes they need complement blocking medications like eculizumab and things like that. So risk factors can be previous transfusion, red cell alloantibodies, and a delayed hemolytic transfusion reaction history. Interestingly, 38% of patients that develop hyperhemolysis are antibody negative. So this bit about signs and symptoms within 25 days after transfusion, certainly it can happen sort of in a longer time course. The few cases of hyperhemolysis I've been involved in have occurred within hours or days. So it can certainly be a very scary situation for sickle cell patients, and up to 6% of patients who develop hyperhemolysis will die. So from a pre-transfusion testing perspective, the most important action by anesthesia is just to communicate the sickle cell disease diagnosis to the lab. You can call a transfusion physician just to actually have that conversation, Indicating it on the pre-transfusion rec is important as well. I know it's often the clerks or the nurses that are filling out the recs, but just make sure that you write somewhere within your transfusion order that the patient has sickle cell disease so that that gets indicated on the rec as well. Of course, we get a sample for group screen and cross-match, and then on the lab, we take it from there. So we look for those non-EBO antibodies in the antibody screen, and then we actually phenotype the red cells. So we have reagents to be able to interrogate the surface of the red cell and understand what proteins are actually expressed on the surface versus what are not. And so when we do an RH and Kel phenotyping, we're looking for the D, C, and E antigens as well as Kel. And then FY is Duffy, JK is Kid, and then the S antigens are also interrogated as well. We can only do phenotyping on red cells if the patient hasn't been transfused or pregnant in the previous 3 months. If they have, then we need to send the samples out to Canadian Blood Services for genotyping. So we will typically genotype most patients regardless of their transfusion status because we want to know if there are any genetic variants present that'll help inform our red cell matching decisions. One of the most common mutations that occurs is a GATA box mutation, which is interesting because it makes the surface of the red blood cell Duffy A and B antigen negative. So it makes them look like they have a super rare blood type that's called Duffy null, but it's actually not the case. They just have a promoter mutation that reduces the expression of Duffy B on the red cell surface. And so we only need to match them for Duffy A antigen, which helps us in terms of the course of blood selection. This mutation is an evolutionary survival mechanism because there is one particular subtype of malaria that uses the Duffy antigen to enter red cells. And so by being negative for red cell antigen expression of Duffy, it actually protects patients with this mutation from certain types of malaria. So this is just an example of what our Saskatoon TML test requisition looks like. And I'm sure most of you have seen that there are little check boxes there for sickle cell disease or thalassemia right by the diagnosis. So if you write pre-op, check off sickle cell disease, perfect. That'll activate our in-lab protocols to understand how to phenotype match the patient. In Regina, they don't have those checkboxes, but they do have the diagnosis section. So certainly indicating the diagnosis here would be important. And anywhere in rural Saskatchewan, it would be important that you know what your pre-transfusion recs look like. And the diagnosis of sickle cell disease should be indicated as well. So this is one of the guidelines that's come out in 2024 that talks about red cell specifications for blood group matching with patients who have hemoglobinopathies. This is standard of care in Saskatoon and Regina, and certainly rural labs are aware of this as well, but often when they get sickle cell disease patients, they're phoning us to make sure that they're doing the right thing. So even if there's no transfusion history or no antibody history, that group and antibody screen is negative, it's the first time we're seeing the patient, we're not just providing them with ABO and RHD matched blood, we're matching for CE and Kel as well, right up front, because we just don't even want one antibody to form. If they have a history of at least one alloantibody or one that's currently present, they get RH and Kel matched blood as well, if feasible, matching for Duffy, Kid, and S antigens. Now, I say if feasible because we certainly do our best. The previous iteration of guidelines was more firm in terms of how highly matched the unit phenotyping should be. It's relaxed with these extended matched antigens. Of course, the unit has to be negative for whatever antigen the patient has an antibody against. But in terms of prophylaxis, the rules have relaxed just because it can be so logistically difficult to get fully matched red blood cells otherwise in these patients. So we do our very best, but in terms of prevention with these extended antigens, that's where the rules have softened a bit. For those that may not have noticed, there actually is end labeling on the unit. Right at the bottom here, there's a special testing section where units will be marked if they've been tested by CBS to be negative for those antigens. So that's very helpful for us in the blood bank because although we group an RHD confirm red blood cells when they come to hospital from CBS, which is a requirement of our standards, we don't have to repeat testing of all these minor antigens, but certainly if the testing's there, that means that we don't have to look for units that are negative for those antigens. So if we need like a 7 antigen match, well, if we at least know that like 4 of those are negative, then we don't have to test for those. We can just test for whatever else that we're looking for. CBS also has a rare blood program, and there's a hyperlink there in case anybody wants to read a bit more about it, that helps hospitals obtain red cells considered to be rare or very rare. They help us with the timeline and logistics of unit procurement based on the patient needs. So this is where the communication and collaboration is really important. If the patient's having a surgery like 2 to 4 weeks out, great, we have time to find units. But if somebody needs specially phenotype matched units like now in 24 to 48 hours, sometimes CBS is moving heaven and earth to get us those units. So we may not actually have certain phenotyped units for patients urgently, and that may impact the timing of surgery, for example, in these patients. So again, communication is really, really important. So getting back to the case, we've talked about the TAPS trial and the importance of transfusion before a medium risk surgery. So yes, this patient would qualify to receive 1 to 2 units preoperatively to hit that target of 100 grams per liter pre-op. So the units must be RH and Cal matched, but preferably full pheno because the patient had the anti-Big C and anti-Big E antibodies. We would hope that we can avoid forming more, but that'll depend on the complexity of the matching. Monitoring for hemolysis should occur per usual protocol. We just have to be aware that sickle cell patients can have a higher risk of hemolysis over the general population. So now we'll switch gears and talk about the new AABB ICTMG clinical practice guidelines for platelet transfusion in patients with thrombocytopenia. So this case is a 65-year-old woman with relapsed AML who's day plus 14 following consolidation chemotherapy cycle 2. Her platelet count is 20, and she has acute renal insufficiency and requires a renal biopsy. Pardon me, a renal biopsy, not a renal kidney. A request for platelets, 3 units, is received to be given now. The request is received at 9 a.m. and the biopsy is scheduled to occur at 1 p.m. Given the clinical information provided, is this an appropriate platelet transfusion request for the patient? So yes, to give 3 units and just proceed. Maybe just give 1 unit and check a stat CBC 1 hour post-transfusion, or no, she's not bleeding, so no platelet transfusions necessary. Those are your 3 options. So I'm sure most of you are very familiar with this graphic in the sense that from a primary hemostasis perspective, we need platelets that are functioning well and that are adequate in number. So of course, platelets are part of that initial plug formation in the site of a vascular injury where collagen's exposed. The exposed collagen is bound to von Willebrand factor initially as a part of platelet adhesion to just bring those platelets to the site of injury. And then there's a whole cascade that leads to platelet activation and aggregation. And then the cascade of secondary hemostasis occurs on the surface of the platelet via the coagulation cascade. So in terms of platelet transfusion requests, these are all screened by the blood bank, and the graphic on the right side shows the protocol within Saskatoon and is encouraged throughout the rest of the province as well. Based on the platelet count, the tech will review the order, and then if something doesn't quite follow the algorithm, the transfusion physician gets called. And you'll see that most of these, if a transfusion is indicated, ends at issue 1 unit of platelets. So the rationale for technologist screening is to make sure that we're reducing exposure of patients to transfusion risks if there truly are requests not in accordance with guidelines. It also protects our inventory. So important to understand that we're 3 hours away from CBS Regina. We have 11 platelets in the city at any point of time in Saskatoon. And so we need to be careful. So I, as a transfusion physician, am not just thinking about the patient that I'm getting called about, whether it's by an anesthesiologist or another colleague. I'm thinking about all the patients in the hospital, plus those that haven't hit the door yet. That's how I'm managing my inventory. So if I'm getting a 3 unit request for 1 person, that's like a quarter of my inventory that could be going out the door. So I need to make sure that that's actually necessary. Regina General Hospital holds less platelets just because they're 10 minutes from Canadian Blood Services and can get restocked at any point of time. You might think, well, why don't you just hold more platelets? Well, they have a 7-day shelf life, and our discard rates are already in the 15% range, but we can't push that down any lower because as soon as we lower our inventory to reduce our outdate rates, we put ourselves at risk of being short. So inventory management is a delicate balance. So indications for platelet transfusion are, of course, treatment of bleeding because of thrombocytopenia or platelet dysfunction, whether that's acquired or congenital, as well as prophylaxis of bleeding in the setting of critical hypoproliferative thrombocytopenia, so a count less than 10, or pre-procedure in specific settings. So I'll just point out a few key highlights from these guidelines. There are more statements that are made, so you're more than welcome to go and consult the full document if you're interested. But in the setting of both adult and pediatric patients with thrombocytopenia, in terms of the certainty of evidence, the strongest recommendations are made for patients, again, with hypoproliferative thrombocytopenia, usually due to chemotherapy or undergoing stem cell transplant. If the count is less than 10, even if they're not bleeding, we know that these patients have better outcomes than if we wait to transfuse them when they are bleeding. And there was the TOPS randomized controlled trial in 2013 that showed us that. One of the new recommendations is in patients undergoing lumbar puncture. The previous guideline used to say a platelet count less than 50, and now it's been dropped to less than 20. And there's fairly robust evidence showing that we don't need a platelet count for that. Importantly, a lumbar puncture, this is diagnostic lumbar puncture. These guidelines don't address spinal anesthetic in any way in the context of thrombocytopenia, like an epidural, or again, just a spinal. So you'll need to rely on ASRA guidelines, which again, I'm aware are a bit gray in this area, unless it's patients who are in the peri-delivery context. So hopefully with time, there's better clarity too in terms of thresholds with regards to spinals and epidurals that comes forward as well. In terms of patients who are non-bleeding, but who are undergoing autologous transplant or who have aplastic anemia, there are some sub-analyses of the TOPS trial that suggest that no platelet transfusion prophylactically is necessary for those groups. This is a bit controversial in the hematology world. Some practitioners will still prefer to follow the same platelet count less than 10, give a platelet strategy. And then the certainty of evidence becomes a bit lower as the guidelines go on in terms of these conditional recommendations. So when patients undergoing interventional radiology procedures, they're making a bit of a blanket statement here in terms of less than 20 for low risk and less than 50 for high risk procedures. I will say that these recommendations align with the 2019 Society of Interventional Radiology guidelines and are already a part of our provincial platelet transfusion guideline thresholds. But truly, it's interesting how most of the data is actually retrospective, which is why it gets a low certainty of evidence grading, because the randomized controlled trial data is just not there. I think one could challenge the ethics of giving platelets versus not giving platelets in certain settings where we conventionally will transfuse based on the retrospective data that we have. And then finally, in adult patients undergoing major non-neuraxial surgery, platelet count of 50 remains the threshold, and that's unchanged compared to the 2015 guidelines. These last statements relate to non-thrombocytopenic patients undergoing cardiovascular surgery. So if they're not bleeding but are going on pump, they don't need platelets prophylactically, okay? So if they're bleeding, it's a different story, but if it's prophylaxis, the platelet transfusion is not necessary. And then in patients with spontaneous or traumatic non-operative intracranial hemorrhage with platelet counts of over 100, this is sort of referring to the patch trial. No platelet transfusion is recommended there. So what kinds of platelets do we have in the blood bank right now? We have predominantly pathogen-reduced platelets via the Intercept Sorlin inactivation technology. So we have pooled and apheresis platelets. One of the important things to note, and you may or may not have noticed, that the volume that's in the bag is actually printed on the label that comes from Canadian Blood Services. You may have noticed that the pooled platelets are now quite a smaller volume than the standard apheresis platelets. So it's just something to keep in mind. This is not harmful in any way to patients based on data that's available. The lower overall volume in the bag And transfusion to patients does potentially lead to a lower increment or a smaller increment. Like if you're looking for at least 15 to 20 points of increase, you might only get 10 points of increase, but there are no differences in bleeding outcomes in patients who get a lower volume of platelets versus a larger volume of platelets. So from the bleeding outcomes perspective, no difference. If we have patients who have allergic type reactions to these pathogen-reduced platelets, we can get apheresis platelets that just have the platelet additive solution added. So rather than the platelets being resuspended in predominantly plasma, they're resuspended in predominantly this PAS solution, and they're a bit more inert. The benefits of platelets that are pathogen inactivated is they also have some lipids and additional antibodies reduced because of the PAS dilution, in addition to being pathogen inactivated. And so they actually are less allergy provoking, and patients will have less risk of things like TRALI as well that are antibody mediated. We do have access to the non-pathogen inactivated platelets still, but we would really have to have a good reason to order those because we know that the pathogen reduced platelets are safer overall. So this is sort of what I was saying, is that there's the reduced risk of transfusion transmitted infections. There's no need for CBS to do the bacterial testing anymore preemptively, so we get the units at the hospital level faster. They are irradiation equivalent, so we don't need to actually put the platelets through an irradiation cycle because the pathogen inactivation treatment deals with the white cells. And again, there are fewer allergic and febrile non-hemolytic reactions. There were no safety concerns when studies compared the pathogen-reduced platelets to untreated platelets, with no increase in thrombosis or bleeding events or mortality. So the bags look a little bit different. The ports look a little bit different. I think by this time you will be familiar with the new Sorlin-treated platelets on the right, and any manufacturing details. If you're wondering, is this Sorlin-treated, is this standard? It's always printed on the bag. So as I mentioned, there can be lower platelet count increments seen, but the Plato trial was the one that showed there was no clinically significant difference in bleeding between low, medium, and high dose platelet groups. One of the aspects that we have noticed, though, is that there's a potential increase in requirements to meet target. So if you're prophylactically transfusing a patient, like in our pre-renal biopsy patient, we may need, rather than just one platelet, maybe we do actually need 2 platelets before the procedure in that setting. We also have noticed that there seems to be an increased trend towards platelet refractoriness, so just the increments not being robust at all. And it's not just because the count doesn't go up. There's something that seems to be consuming those platelets. It's not antibody mediated, but it's something we're continuing to study with the nationwide introduction of these pathogen-reduced platelets. So there is some detail available in this great publication that was just published in May that talks about managing patients who are refractory to platelets. So what's important for the anesthesiologist to know? Well, it's not okay to just transfuse a platelet and presume that the patient's fine for surgery, or presume that the patient's fine for that interventional radiology procedure. Particularly patients who are inflamed or who have cancer or who have a multiple transfusion or pregnancy history, they can actually have antibodies that develop against the platelet surface antigens, and that can cause increased consumption and lead to bleeding if there's a false sort of assumption that the target platelet count's met without actually checking. So what we're asking you to do is, if you are transfusing platelets before a surgery, just always do a post-transfusion CBC about 1 hour after, or within an hour after even. It can be 30 minutes, just to make sure the increment is going up by at least 5 to 10 times 10 to the 9 per liter. Because depending on that increment with one unit, we'll know whether we need 1 or potentially even 2 more platelets. If you're trying to go, let's say, from 20 to 100 for a neurosurgery, like, that's different. We're going to be talking about inventory management in these aspects, but it'll help us understand how many units you need. Sometimes patients will respond well just to 1 unit of platelets, but we don't know that unless you check, okay? If you do end up doing that post-transfusion count and you're not seeing an increment of at least 5 to 10 times 10 to the 9 per liter, give us a call so we can A, know that we might need more inventory dedicated towards that patient, or B, there may be an appropriateness of actually checking for the HLA antibodies. So this algorithm just kind of walks us through on the blood bank side of how we manage the suspected platelet refractoriness. First, we transfuse ABO matched platelets, and then if that's not really working, as opposed to just ABO compatible, they'll be ABO identical. If that's not really working, then we'll have to pursue consideration of HLA antibody testing. We do the HLA antibody testing right at St. Paul's. We have a wonderful ASHI-approved lab under the direction of Dr. Mustafa. So if antibodies are found, we can request HLA matched platelets from CBS. If a patient isn't known to have HLA antibodies, it can take 2 weeks or so, 1 to 2 weeks to actually obtain HLA matched platelets if they actually need to call a donor in to donate a certain specific type of platelet, if the unit's not available on the shelf somewhere in Canada already. So again, time and conversation is really important to make sure patients have the product that they need. So getting back to this patient that needs her renal biopsy, it would be correct to give 1 unit of platelets and then check a stat CBC 1 hour post-transfusion just to see how close you're getting to your goal. The patient may not increment at all, or maybe she'll increment well and go from 20 to 45, and you may just need 1 more unit. So we don't need 3, we might just need 2, right? So it's really important just to consider what's needed for the patient, but also preserves our inventory so we're not over transfusing anyone. The last part is to describe hemostatic management strategies applicable to patients taking direct oral anticoagulant medications. So this is a 70-year-old male coming to emerge with an acute left femur fracture after a fall from a ladder requiring surgery. He has AFib with a CHADS-2 score of 2, and he's currently anticoagulated with apixaban 5 milligrams BID. His medication also includes ramipril for blood pressure management. He routinely takes his medications in the morning, including today. Surgery wants to take him to OR as soon as possible because of the nature of his fracture. So you can see he's a little bit tachycardic. He's 80 kilos. Routine blood work showed a hemoglobin of 125 and a fine renal function. So what's the appropriate next step in managing this patient? Do we measure an anti-10A level to assess pre-op bleeding risk? Give PCC within 1 hour of surgery? Give PCC intraoperatively if bleeding only? Or try and procure some andexanet alpha? So just a reminder that the direct oral anticoagulant medications have specific effects on the coagulation cascade. So the 10A inhibitors all have XA in them. And so these ones directly block factor 10A. And then dabigatran is a direct thrombin inhibitor. I think we're seeing this one much less frequently than in the past. And we do have Praxbind that's a direct reversal agent. So we have a very clear algorithm as to how to manage bleeding and preoperative care in the setting of dabigatran. So from like the standard coag screening perspective, with dabigatran on board in patients, you can potentially see a prolonged PTT, not always, but you can. But it definitely prolongs the thrombin time. So the thrombin time is a very reliable screen for just, is there any dabigatran present? We know it's extra super sensitive. So if it's negative, it's a very reassuring test. Things get a little bit murky when we talk about the 10A inhibitors and understanding whether there's any drug on board in the absence of specific drug levels. So we know that the 10A inhibitors may prolong the INR, but there can be therapeutic drug levels in a patient's plasma, particularly in the context of apixaban, and the INR can be perfectly normal. So the INR is somewhat useless, is what I'm saying. So you can't rely on conventional coag testing to tell you anything about the anticoagulation status of patients on DOACs. So there's been a bit of controversy about this lately, so I just wanted to provide some information about what is currently done in Saskatoon and Regina. And so anti-10A levels wouldn't be available anywhere outside a special coag lab. So these are not routinely done before surgery. There's no firm clinical practice guidance as to how to use anti-10A levels pre-op in the setting of 10A inhibitors. Guidelines can support consideration of circulating factor 10A inhibitor impacting coagulation based on the last dose. So these are like the Thrombosis Canada guidelines and some of your ASRA guidelines that talk about how many hours there should be in between the last dose based on the renal function, the actual dose of medication the patient takes, and how long it's been based on the drug half-life. So If the timing of the last dose is unclear, the anti-10A level has been described as a sensitive screening test for the presence or absence of the drug. But there's a huge caveat here, and that's only if there is a calibrated assay using an anti-10 reagent specific to factor 10A inhibitors that's used. So in Saskatoon and Regina, we currently have the ACL top instruments where RUH and Regina General Hospital can do anti-10A levels. But the only reagent we currently have is this liquid anti-10A that is abundantly, very clearly described to be specific for quantitative detection of unfractionated heparin and low molecular weight heparin. And both of our labs have lab policies that say this test is not to be used and will be canceled in the setting of fondaparinux as well as in the factor 10A inhibitors. So we heard a couple of weeks ago that your ASRA guidelines do suggest that if an anti-10A activity of 0.1 units per mil or less is present with the use of an unfractionated heparin or low molecular weight heparin calibrated chromogenic assay, that this level could be considered to be undetectable in terms of anticoagulant effect. So there are a couple of problems with this from the lab perspective. With this bold statement made, there's no consideration of what instrument and reagent were used. And we know there are different instruments and reagents there that are available in the world. The other thing is that when we talk about what's a negative cutoff for unfractionated heparin and low molecular weight heparin, our cutoff isn't 0.1, it's 0.04 units per mil. So it's a little bit unclear to us how this 0.1 was even chosen. So I went and looked at the references that sort of are used to try and support this statement. And reference 58 actually very clearly states that different reagent sensitivities and variabilities in lab calibrations impact assay results, and that calibration standards for all specific tests for each DOAC are needed to reduce interlab variability. So trying to apply a test that is intended for one purpose to another purpose can actually lead to erroneous conclusions. And so we've talked about this amongst us in the labs, and we're not going to be performing anti-10A levels on patients on DOACs just for the sake of safety. What we have committed to doing, though, is looking at the cost and feasibility of the Werfen DOAC anti-10A reagents. They do exist in the catalog. We've never brought them in, but we are going to be looking at how much does this cost. What is the potential for bringing it in? Because certainly our analyzers can run them, but we would need to consider what's the implementation and validation process like. When would this test be done? Is it only going to be done once or twice a month? And is that justifiable in terms of not just bringing in the reagent, but also the quality control aspects within the lab to actually justify the testing? So there will be more conversation to come, but at this point of time, we just can't safely report these levels outside of the context of unfractionated heparin and low molecular weight heparin. So how do you approach a bleeding patient who's on DOACs? Well, there's a nice algorithm on the Treat the Bleed website that ultimately gets down to controlling surgical hemostasis, and if patients are on a 10A inhibitor, thinking about using PCCs, and I'll address undexanet in just a minute or so. So it's not okay to use it's not okay to use recombinant 7A or frozen plasma. There's no evidence that those work. Vitamin K can be used as a nutritional supplement if you suspect that there's concurrent vitamin K deficiency. I had an interesting case just last week where there was a patient that presented with an INR of 8, but was on a DOAC for atrial fibrillation. And so that is highly out of keeping with what we would see. And by the way, the liver function was normal. So certainly if we see any DOAC effect, even in poor renal function on the INR, it's usually an INR of like 2, maybe 2.5 at worst. And it was a PIX, which tends not to impact the INR at all. So with an INR of 8, this chap must have had some concurrent nutritional deficiency. So he definitely was a patient that received vitamin K and did well from that as well. So PCCs are a concentrate of vitamin K dependent clotting factors, 2, 7, 9, and 10. I think everybody here is familiar with PCCs and the benefit that we have in reversing warfarin. We do know that PCC is an effective bleeding management strategy in the setting of factor 10A inhibitors. So it doesn't completely reverse the DOAC effect, but what we now know is it appears to drive excess thrombin to overcome the anticoagulant activity. So it essentially pushes through the coagulation cascade to bypass the inhibition and produce excess thrombin to then drive more thrombin production through the feedback loop. So again, we can't measure the effectiveness of the PCC that's given in the context of 10A inhibitor bleeding, but we can assess clinical benefit. So the NAC statement does support use of PCC on an individualized consideration basis with either a standard dose of 2,000 units or a weight-based dose up to a maximum of 3,000 units. So there are some retrospective studies that are pretty convincing, small populations even still, but pretty reassuring in that we're doing benefit to patients and reducing bleeding and not causing harm. This one study was out of Ottawa and actually looked at a weight-based dosing, retrospective cohort study, weight-based dosing of patients receiving PCC with DOACs on board before urgent surgery or in the setting of major bleeding. And they did find that there was a positive overall clinical effect without any major increased risk in thrombosis. They still saw that the thrombosis rate was 7.8%, but there was efficacy achieved in terms of reducing intraoperative bleeding complications in patients. This study, called the Proxy trial, is actually the only prospective study that looks at the use of 10A inhibitors in the preoperative world, and it actually only had 20 patients. So it's very small. We need more information. But once again, it showed that there was an effective reduction in bleeding in patients who received this treatment before surgery. It was a fixed dose of just 2,000 units, and there was only one thrombotic event seen, so 5%. It was 1 of 20. So again, very encouraging data. It's nice to have something prospective, but we certainly need a larger study. So finally, excuse me, finally, andexanet alpha has been a hot topic of conversation as well. So this is a direct reversal agent that's a recombinant modified human factor 10A protein that's intended to directly bind to rivaroxaban and apixaban, essentially freeing endogenous factor 7A. So it's like a competitive inhibitor in the sense that it will bind to the sites preferably rather than the 10A inhibitor that the patient may have on board. So it's indicated in adult patients treated with just rivanapix, not edoxaban, in the setting of rapid reversal due to life-threatening bleeding or uncontrolled bleeding. It's a little bit cumbersome given as an initial bolus with an infusion continuing over 2 hours, and was given conditional approval in June of 2023. So there were several studies ongoing to either confirm or refute its benefit. But everything kind of looked good initially. But ultimately, just this last year, the Canadian Drug Agency, which is formerly CADTH, had reviewed evidence available and has recommended to the provincial ministries that this drug not be reimbursed. And you might think, well, what the heck? If it's a reversal agent, why isn't it available? Well, the cost was extreme, like tens of thousands of dollars per dose. And interestingly, there was limited evidence of benefit in comparison to PCC. So when we looked at the potential to improve hemostasis in the context of andexanet alpha, when compared directly to PCC, it was no better, and there were some safety signals seen. So this was a retrospective review that looked at a variety of different anticoagulants as well as bleeding management strategies. So it looked at PCC, idarosizumab, obviously in patients who were on dabigatran, as well as andexanet alpha. So if we look at the effective hemostasis column on the far right, you can see that the hemostatic effect between 4-factor PCC and andexanet looks pretty good. But there was a huge signal of thrombosis, with upwards of 10% having dangerous thrombosis who received andexanet versus about 4.3% with PCC. So you might say, well, this is really large, it's kind of aggregate, not high quality. That's true. Then there were a couple of other studies that were done. So one was this sort of pivotal andexanet alpha for 10A inhibitor-associated acute intracranial hemorrhage, and was really kind of like the main New England Journal article that everybody was looking forward to know, how beneficial is andexanet really in patients with intracranial hemorrhage. So patients were randomized to receive either andexanet or standard care, but within the standard care arm, 85.5% received PCC. So this was almost like a comparative, unintentionally so, but comparative head-to-head trial between andexanet and PCC. And in terms of hematoma volume expansion, sure, we saw andexanet did pretty well with 76.7% volume expansion reduction versus 64.6%. So this was assessing for hematoma expansion of less than or equal to 35%. So looks good. But the big difference was in the thrombotic complications and then in ischemic stroke. So you can see the andexanet arm had a 10.3% risk of thrombosis and then a 6.5% risk of ischemic stroke relative to significantly lower numbers with the usual care, again, the majority of whom were PCC. So this was very concerning, and it was largely because of some signals in other lower quality studies, plus this result, that actually led to the Canadian Drug Agency saying no. The cost is not justifiable. The benefit is the same as PCC, and if anything, there's greater risk to the patients receiving this product. So thinking back about our patient, certainly measuring an anti-10E level is not useful. This patient just had his drug this morning. It's going to be there. Andexanet alpha is not available. And I've actually highlighted the PCC within 1 hour of surgery and PCC intraoperatively if bleeding only, because there is truly clinical equipoise as to what the best strategy is for patients. I was going to say that about a year ago, I would have been like, yeah, give PCC pre-op. Here's your 2,000 units. Good luck. Lately, my practice has changed a little bit in terms of the recommendation because of what others have been doing. For example, colleagues in Alberta, they have been waiting and sort of pre-approving PCC, certainly for it to be available in patients going for surgeries like this, and say, take the product if you find that the patient's oozy in OR. We know that it has a very rapid onset, like within minutes when it's given, in terms of helping to drive that thrombin production. And interestingly, in the recent couple of cases that I've been involved in like this, where I've just approved the product and said, yeah, use it if you need to, but if you don't, that's fine, especially if patients have good renal function, the surgeons haven't taken it. So I think we're still learning more about whether, just like with the proxy study, we should be giving the product immediately before surgery to all comers or not. The thing we need to consider is that these patients are all on anticoagulants for some reason because of a thrombosis history. So if we do elect to give PCC in these patients, there is at least a 4 to 8% thrombosis risk based on the data that even I just presented here. So if there's truly the sort of presence of major bleeding and the bleeding risk and complications thereof outweigh thrombosis, absolutely proceed with giving PCC. But if it's in a prophylactic setting, one does have to consider whether the minimum 4% risk of thrombosis is worth it versus just waiting if the patient's a little bit woozy in OR. So in summary, a collaborative relationship between clinical teams in the lab is essential to support optimal patient care. The TML team has an important role in screening requests to enhance patient safety by minimizing unnecessary blood exposure. We have lab policies to ensure sickle cell disease patients receive phenotype-matched blood in accordance with our best practice recommendations. Confirming an appropriate platelet increment following transfusion enhances patient safety. And finally, PCCs are an effective bleeding management strategy in patients taking factor Xa inhibitors.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.